just got to play like the magic eye with stuff on the slides, you know, with that radiology stuff. It's Friday. Friday, that's what I said, Friday without a test. There's like 3 of these in all of iPad. Right? Enjoy that. Right? And then when you get to phase 2, well, some of you will test on Mondays in phase 2. It just depends how your phase 2 has it set up. Yeah, in phase 2, you test on the last day of your rotation, so every phase 2 is a little bit different. Most of them, last day of the rotation is Friday. Some are Monday, just because it works better for that facility. So, but okay, going back to last time. Any questions? Okay, so I had some good ones afterwards. So people were asking me last time after we closed class, hey, so we have avascular necrosis, bone is dying. Help me understand why this is a focal increase in bone density if bone is dying. It should be a decrease, right? Because we're losing bone, it's dying. So on the surface, logically, yes, that makes sense. But the reason it's a focal increase in bone density is because as that bone dies, it becomes sclerotic, right? And before it completely dies and is like done, it has that sclerotic change, and that's what causes that increase in bone density, right? So what you're catching is the sclerosis of the bone, and that's why it increases. So it's a little counterintuitive. It's just kind of how it presents on the x-rays and what the body's doing in the process of avascular necrosis. And that's what really makes it jump out more when you're looking for it, is that increase of that bone density. So we talked a little bit about the femoral head last time, right, and kind of what that looks like. Yes, that can happen, but it's more common in the scaphoid than it is in the femoral head, okay? It can happen in the femoral head. Those are the 2 most common places. But the odds are in your career, if you catch this, it's going to be this scaphoid bone, okay? So these are different stages of a person who came in, and the mechanism of injury for this is usually what we call a foosh, right? They fell on outstretched hand. You see this a lot. You trip over a curb, you fall, you brace yourself, you hit impact with hyperextension of your wrist, and all that impact comes in here, and it fractures that scaphoid, right? So the purple circle is the initial x-ray, all right? For all intents and purposes, this is normal. So if we're looking at it, and we're following through the cortex, right? We're going through every single area of the x-ray, and just because we're looking at the scaphoid, right, don't forget, when you're reviewing these films, to look at every single bone that is on there, and follow that cortex and look for any of those breaks. Does anybody see any on the purple circle at the level yet where you're like, maybe something to watch for, not really sure? Use your computer instead of the PowerPoint. Sometimes it's a little bit easier for you guys to see because you can zoom, right? I'll give you just a second. If I'm giving you a second, there is something small there. It's okay if you don't see it yet. And here's why it's okay if you don't see it. And I'll explain that in a second, right? So right here, there's a small lucency or radiolucency right there in the cortex of that scaphoid. Now, if you didn't pick that out in clinic, is that a big deal? Right? This is pretty significant in the aspect of avascular necrosis. It's not if you give them the right counseling. And the correct counseling, like we talked about last time, is, hey, x-ray, maybe you missed it, right? It looks normal. Radiologist might even see it, like, I don't see any issues going on here. But if it's not any better in 7 to 10 days, I need you to come back so we can repeat the x-ray. If you give that counseling, missing that small little radiolucency in the purple circle from a clinic standpoint is perfectly okay, right? Because they're going to come back. You're going to reshoot the x-ray when they're still symptomatic, and it might look like this. Okay? Go ahead.
So on the previous slide with AVN, before that one, you said it, when it's actually talking about it, you said it could be asymptomatic.
Correct.
Are you ever just going to have, like, say somebody douches, they don't really have symptoms, but in the initial x-ray is benign, and then are you just going to tell them to come back in 7 days?
No. Because the majority of those falls, right, we're not going to radiate and continue to do x-rays and use appointments for things that are normal. Yes, it can be asymptomatic, right? But most of them are not, but it can be. So the reason I put that in there is if somebody comes in and they fell on outstretched hand, right? But they're like, yeah, actually it feels pretty good. I still want you to get the x-ray, right? That's the part where the asymptomatic place comes in. Still get the x-ray because you might see the fracture. Don't just be like, oh, you're not having any pain in that area? Okay, cool, you're fine, you probably just fell, no big deal. No, get the x-ray, all right? Same thing with the femoral head. To answer the other part of that question of, could it happen to where maybe you did this, they got better, right? They didn't come back, and they ended up with avascular necrosis. Can that happen? The answer is yes, it can. But ultimately, the percentage of people that would happen to is really small, and then really you look at, right, it's called practicing medicine for a reason, right? We can't be 100% perfect, 100% right all the time. As long as you've done everything right with the information provided you at that time, that's a bad outcome, but it's not a bad outcome because you gave bad medicine or bad advice, right? So good question. No, do not x-ray everybody who fell on their wrist 7 to 10 days later. If they get better, they get better, because the majority of them will, okay? Good question. All right, so anyways, going back to this, right? So that's the fracture that comes up afterwards, right? That's what we're looking for on that repeat x-ray. And then I have it broken down on this slide here. This is where you start off with normal. Eventually you get that denser, white, sclerotic bone. That's what kind of notifies you on that early stage of avascular necrosis. Later, we start to get the actual bone fracture and collapse. So it starts to fracture here. On that femoral head last time, we saw how it collapsed down in this area here, okay? And then we get the degenerative arthritis afterwards. That's down the road, right, after they fix this. Any kind of surgery or fracture, anything like that, is going to increase the risk of arthritis in patients. Especially these ones are going to be degenerative arthritis. And we'll talk about different kinds of arthritis in here today, and how to tell the difference between them just by looking at x-ray and patient history. But know that this is a surgery, right? They're going to have surgery on this if they fracture their scaphoid. Questions on this slide and kind of that stepwise process? Okay. Right? Here's some more pictures of it to kind of give you an idea. So this one I like because it starts off again with what is a normal x-ray. All right? Following all of my carpals, they fell, everything looks right. I do my cortex, I do my medullary, I jump into my joint spacing and my joint alignment, right? Look at all that, everything looks good. They come back, I'm starting to see a little bit of a difference here. Now, I want you to look at how sclerotic, right here where the blue arrow is, see how much brighter white it is than the one on the left, right? If I gave you right now this stage, just this one, right, as far as the sclerotic goes, maybe you put it out. If you took this and you compared it to the other carpals, which is fair game, you'd be like, hey, maybe that looks a little bit different. But right now, you're still kind of seeing this stuff, right? So I compare it to the one that's over here, just so that way you have the two comparisons on each side, okay? Plus there's the big red fracture line, right? That's on here too. But I'm more focusing on that sclerotic area. That's the part of the bone that's dying right now on this particular picture. All right? Now I show you the MRI as the study of choice. This MRI in particular is an MRI of a patient who had multiple normal x-rays, but they were still having pain, that process I told you about, right? Come back, got another x-ray, it was normal again. Okay, wait another week, come back if it's still bugging you. They came back, it was still bugging them. They got an MRI, and the MRI makes that fracture jump out right there, that scaphoid, right? This patient is likely still going to get surgery. I'll let ortho kind of focus in more on that next semester, right? This patient's likely going to get surgery. But that's why that MRI can make that scaphoid fracture pop. We don't normally use MRI for fracture evaluation, except in the case of avascular necrosis. Because even if we couldn't see the fracture, if this was starting to sclerose, starting to die, we would have increased signal, so it would be brighter white also in the scaphoid as well. So we may not see the fracture, but we would see increased whiteness from the MRI somewhere in that bone. And that's really why we jump into the MRI as a study of choice. We don't want to miss these things. I'm not gonna do treatments in this course, so you don't have to worry about knowing that surgery is the plan of care, right? It's just giving you tidbits, so when you see it next session, you're like, oh, I remember that, I'm gonna study it again. Right, we do surgery on these things. X-ray initial study, MRI study of choice. So how could some of these questions look like? So you're a sophomore semester, right? So you still have a lot of first order questions on your exam, but as you've probably seen, you're starting to get some of those second orders, right? Maybe a third order here and there, not so much, that'll happen up in juniors and seniors. So for something like this, I can give you an X-ray and a patient who fell on the outstretched hand and just be very simple and tell you like, you know, they have a scaphoid fracture, you know, what's the initial study or what's the study of choice, right? And that's the first order question. I just gotta know that I'm concerned about avascular necrosis or scaphoid fracture, so I'm gonna get an X-ray or an MRI depending on how I ask the question. If I want to second order it, I don't tell you what's wrong with them. I give you a patient who injured themselves, I give you a picture, and then I just say, based off of the history and the image, what is the study of choice? Now you have to look at that, figure out what the condition or the issue is, and then how do I confirm that with what kind of study, basically. So that's what a second order would look like. I talk about the disease and figure out what you're concerned about, and then what do you order, but I don't tell you what the disease is. There'll be some of both. And then don't forget, there'll be at least one, not more than one, but at least one normal X-ray. So you gotta know what normal looks like. It's not just about finding the abnormalities. It's about looking at it and going, you're fine. Just go to physical therapy or give it a couple of weeks and come back, right? That's just as important as finding the fractures. Right. Paget's disease, very briefly, right? FYI slide, do not create a lot of brain cells to this, all right? But it's a focal bone reabsorption and a disordered bone formation. Biggest thing, pelvis and lumbar spine. That's where you're gonna see a lot of the Paget's disease is pelvis and lumbar spine, okay? 70% of cases are asymptomatic. We gotta love math and numbers, right? Statistics you can twist any way you want. 70% of cases are asymptomatic, but pain is in 74% of cases. How the heck does that add up, right? So what does that mean? If I have 100 people, 70 of them are gonna be asymptomatic, right? But of those 30 that are symptomatic, what, 75% of that? So 22, 23 are gonna have pain, right? So that's kind of why those numbers look like that. Right, just know that it can be a very asymptomatic case. Biggest thing with this one, X-ray, notice how it's blue. X-ray is your study of choice and your initial study. It's both, right? So really we just do it blue because it's both, it's a study of choice. And what you're gonna see is this. This is your Paget's disease, okay? So how do I know that's what's going on here? Well, there's three key factors to Paget's disease. One, you got that thickened cortex over here. Again, normal, abnormal. Thickened cortex, and then a more prominent trabecular pattern within the bone compared to the normal side. Everybody see that? Really look how thick that is. Even if you just compare it to your fibula right behind here, right, you see how thick that cortex is, and then that more prominent trabecular pattern. You usually end up having the bowing of the tibia when you see this, just because the bone is weaker, okay? And then the bone almost looks thicker. You see that? The tibia almost looks thicker compared to this normal one. When I compare the same views to one another, I compare the lateral view, side view, right, compared to this guy, it's thicker. Those are your three key things with Paget's disease. There's not many things that look like this that aren't Paget's. You will see this more in pediatrics. Now, how do I know this is a pediatric X-ray? We haven't covered this yet. Anybody know? Use the normal X-ray to look at it, not the abnormal.
Growth plates.
Growth plates, right? So look at the growth plates here, 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 and here. You can see the growth plates, okay? That's how you know this is a pediatric X-ray. I have growth plates. If there are no growth plates, it's an adult. How old is this kid? I have no clue, right? There are ages which you will learn in peds where certain growth plates fuse at certain times. Those are general guidelines, right? Every kid's a little bit different. I am not gonna, there's only one case when I'm gonna give you a pediatric X-ray, typically, and have you try to evaluate for a fracture. That's called a Salter-Harris fracture. We'll get to that. And that's because it is a fracture of the growth plate that's really, really important. But outside of that, I don't give you a lot of pediatric X-rays. Why? because I don't need you to know when those growth plates fuse and when it's an actual fracture. Even your regular radiologists aren't always good at reading this. They have a special, like, subspecialty for pediatric radiology. So they become a radiologist first, and then go to more school to, like, just specifically learn pediatric radiology because of the growth plates and how detailed and how important it is if you miss something on one of these, how much it can actually damage the kid's growth and other issues in life and stuff like that. So I'm not needing you guys to become experts in pediatric radiology, except for Salter-Harris fractures, and we'll spend quite a bit of time on that, looking at those, because you can't miss those things. But growth plates will tell you adult or peds. Alright, so we just covered all that from last time. So the generalized increase in bone density, the main one I need you guys to know about is the osteopetrosis, right? That was the generalized one, okay? And then the localized one, the main one I really need you to focus on is avascular necrosis. That's the one that you can't miss when you're in clinic. Questions on those guys? Okay, so here we got bold and underlined, the ones I want you to focus on. Hyperparathyroidism, we're going to briefly discuss, but it's more to prep you for next semester too. But generalized decrease in bone density now. So the first one is osteoporosis. You will see this often, okay? So what's the top cause of osteoporosis? Menopause, age, right? Age and menopause, more in females than males. Why? Because of the hormone changes, right? They end up with hypogonadism. They go through the menopause, they start having issues, they'll get into it in endo and women's health. They start having issue with their estrogen and their progestin, and it ends up having issues with bone density, okay? So most commonly in women postmenopausal. So if I give you a 65-year-old female or a 72-year-old female, before even looking at anything, right, depending on how you take your test, osteoporosis should be on your differential, especially if they're having any kind of bone pain, back pain, that kind of thing. So what happens is due to the hormone changes, the osteoclasts are overactive, right? And we don't have the osteoblasts to kind of make up for it. So they're too overactive, so they start degrading that bone density, and the osteoblasts are underactive. Trabecular bone turnover is more rapid, so we start getting that first picture we had, right? The more spaced out trabecular bone. It's really kind of airy. It's going to be more radiolucent, okay? Spine and pelvis are the two primary areas, and I'm going to expand pelvis to kind of like the main hips, right? The femoral head, the femoral neck. That's where a lot of these osteoporotic fractures are. They're either in the spine, typically lumbar, sometimes thoracic, and the femoral neck area, as opposed to the pelvis, but it's kind of all together in that aspect. Most of these patients are asymptomatic. They don't have an issue until they fracture something, right? And yeah, so we got that. X-rays is how we'll note it first, in yellow there, right? Initial study. And once you get used to seeing normal on these things, what's going to happen is if they're not diagnosed with osteoporosis, you're going to get an X-ray on something that's bothering them, and even if there's not a fracture, you're going to be like, I think you have osteoporosis. We need to jump to the dual energy X-ray, don't say the A word, that's hard to say, but DEXA scan, okay, is the study of choice. So, what is a DEXA scan? A DEXA scan is basically like a low absorption X-ray. It's less X-rays than normal. We're not looking for fractures. We're truly just evaluating the density of the bones of the patient, okay? You don't have to know how to do a DEXA scan. You don't have to know how to interpret a DEXA scan, because even your X-ray techs don't know how to interpret a DEXA scan. It's a computer model. The patient goes, they scan the lumbar spine, they scan the hip, and they compare it to a computer database that has what their density should be for the same age, race, sex of that patient, and then it spits out a number saying, hey, they're osteoporotic, they have osteopenia, which is in between, or they're normal, right? So you will order these DEXAs though. Why is it not here? If you don't have to interpret it, because you'll order them, because they're standard screening for women of postmenopausal age to try to catch osteoporosis before it becomes osteoporosis when it's just osteopenia, right? And so that way you can treat them with medications. I don't know if you've learned that in pharm yet. That might be next semester. Have you learned that one already? No? Bisphosphonates? PAC a little bit? Okay. So the idea is that you would do this as screening, so that way if it's in that osteopenia range, you can start treatment early to try to prevent osteoporosis from happening, right? So that's why that's on here. That's why knowing the study of choice for osteoporosis is important, because you will order that more than you'll order regular x-rays for it. Really, the regular x-rays will be incidental findings. Here's everything I just talked about, only in a nice little picture to show you the trabecular framework and what happens as we get older. This is why grandma has a hunchback, okay? Grandma doesn't have a hunchback because she's a big fan of Quasimodo and went to Notre Dame to visit. Grandma has a hunchback because years and years and years of weight on the spine, right? And then the decrease of that trabecular pattern, it hurts, it compresses down, and now she either leans this way because it hurts to stand straight up and put all that weight on the spine, and then she ends up with the hunchback, or those vertebrae are starting to compress because they don't have that strong trabecular framework like they used to, and so it's kind of shortening her, right? That's why we get shorter, all gonna get shorter, primarily women. Yes, ma'am?
For all intents and purposes, what age are we considering to start at postnatal?
It depends by patient. Patient history, right? For this course, I would say anybody, we'll say 55 and up for this course, right? But it does vary by patient. I have had patients who went through menopause at 43, right? So it just depends. So we'll say 55 for here. If I give you one on the test, right, I am not a huge fan, and I know I've heard this before, I am not a huge fan of trying to trick you guys, right? In the aspect of like, I'm not going to give you a 54-year-old and be like, oh, you should have known. If I give you one, they're going to be in their 60s. It's going to be clearly postmenopausal age, right? Because you haven't learned all that yet until women's health in senior semester. So I can't ding you on something that you haven't gotten the details on. Sir?
Does this present with serum hypocalcemia?
Not all the time. Sometimes it can, right? Depending on how severe it is and how rapid it's happening. But the body has a really good way of, what's the word I'm looking for? Sorry, it's Friday morning for me too. Compensating and kind of adjusting for that, right? So not all the time. So here's what it kind of looks like. This is a foot, right? Not one we normally check. But this is kind of what I'm saying is where sometimes you will find it just by ordering a regular x-ray. Hey, I stubbed my toe. Or I dropped something, I dropped a can of peas on my foot, and my foot's been hurting. So you get the x-ray. This is normal. Normal. Look at that beautiful, bright, kind of trabecular pattern. And then here's my abnormal. There are no fractures in this right now. This is just pure osteoporosis. So look at, I want you to focus on the medullary and the trabecular bone area on the two x-rays. This is how you find it incidentally. This is where you go, hey, you dropped a can on your foot, and I got the x-ray, there's no fracture, but have you ever been diagnosed with osteoporosis? No. Let me go ahead and order you that DEXA scan and get this looked at, because we may need to get you on some meds to try to prevent actual fractures in the future, right? So does everybody see how much more radiolucent that medullary canal is, the trabecular pattern, whatever words you want to use for this course, right, are compared to one another. Okay? This here is just dealing with technique. This bright white down here, this is not anything. This is not like an osteopetrosis starting or anything. It's just osteoporosis throughout all of those bones. You see that? Here's what it looks like in the spine. Okay? So again, normal, beautiful, right? Look at these vertebrae, nice and square. I have this wonderful kind of light gray medullary area in all these spines. They all look very, very similar. And then I jump over here and look how dark, look how much more radiolucent the inside of the spines are on this abnormal one. On top of that, I'm starting to see, right, some compression fractures starting here. We'll talk about that more a little bit later when we get into that. But look at how not nice and square these things are. Kind of swooping in a little bit. Starting to get some anterior horns here. We'll talk about that. That's an arthritis thing. But you can see how I got a nice square vertebrae, and then I have like this little swooping area. What that is from the weight of the body, right? The vertebrae is not as dense, it's not as strong as it used to be. So now over time, that weight from holding the weight up kind of just starts to compress that vertebrae down, okay? And then these other two on the other side, these are all abnormal as well, all right? Compressed area, much more radiolucent than my normal. This guy here is starting to do that compression on both sides, right here and right here, okay? Starting to compress on both sides. but still having that radiolucent center. Does that, and I know you gotta look at them some more, but for now, does this slide kind of stand out between the normal and the abnormal? Okay, yes, sir?
So just to define, like, if you're using the term sclerotic, like in the ABA presentation, do you use that to describe this as well, or more so like radiolucency?
So different, right? So I'm using radiolucency, because remember, sclerotic is a reason for more radiopaqueness. So remember, radiopaque and radiolucency we are using to describe either the darker or the lighter, okay? So you can say sclerosis causes a radiopaque section of the bone. But sclerotic is a process within the body. Radiopaque is just describing the density on the film. Does that make sense?
Yes.
So sclerotic areas of bone are more radiopaque than normal bones. Okay? Which means if you wanted to compare the two, a healthy bone would be more radiolucent than a sclerotic area of bone. Does that make sense? Okay. So remember, radiopaque and radiolucent are describing how bright they are, how dense one is compared to the other, but sclerosis is actual metabolic process that's happening due to the avascular necrosis. Okay? Yeah.
With the foot versus the spine, the foot is like below weight versus the spine, which is.
Someone down here?
Yeah.
Yeah.
No, up higher.
Here?
Like the actual metatarsals, they all look pretty bright versus the spine, which is very radiolucent.
Good question, right?
Like,
why is that? Good question. So, what's that?
And more tissue?
More tissue, and he's exactly right. So when I shoot an x-ray on a foot, I have very thin area to go through, right? So that cortex and stuff's gonna pop a little bit more compared to that medullary canal, because I have just this thin area of a foot to put the radiation into. When I do a lateral spine x-ray, I'm pumping radiation through all of this tissue. So there's more of that radiation is getting dispersed, more of that is getting absorbed, so you don't have as bright of a contrast in there because of the spine. Okay, so good question and good thought process there.
Sir, so like when you're looking at your x-ray, contrast like that's like as high as you would, that's the highest contrast you would.
I'm confused with your question.
Like when you're looking at the spine versus the foot.
Yeah, so okay. Do not compare spine x-rays with foot x-rays. They're different techniques, they're different amount of radiation, right? I don't want you to get confused, right? I don't want you to get too messed up, like, well, how come the foot looks like this and the spine? I want you to compare normal spine with abnormal spine and normal foot with abnormal foot.
Well, I know you can turn it with the, like you can turn it different.
You can, but that's gonna be solely related on your x-ray tech and how they do the x-ray. And it's gonna be at a level that you guys won't have any control over, and I don't want you to spend brain power on it, right? So just kind of stay on the surface with that, compare light x-ray with light x-ray. Don't try to put the two body parts together, because as you were just saying, there's a lot of factors that go into that. Size of patient, right? Was the right technique used? Did they give enough radiation? Did they give enough? Because there's two types of things. You can do the amount of radiation to take the picture, and you can also do the power, right? The speed of the x-rays that can affect the picture as well. And because there's so many variables there, I don't want you to do that, because it's going to vary by patient and by technician who took the picture. So just body part to body part. Any other questions? All right. Questions on osteoporosis. So biggest thing with this one, right? Look at your normals, get practice with it, compare it to the abnormals of looking at that that increased radiolucency or decreased bone density, right? And so look at that, know the age of the patients you're probably looking for. Can a 42-year-old male have osteoporosis? Sure, they can. Is that the normal? No, it's not. So I'm not looking to throw that kind of stuff at you, but understand that. Understand that x-ray is the initial study, but the study of choice is the DEXA. That's how you diagnose. That's how you know right where they're at, so that way you know if you need to treat or not. All right. Hyperparathyroidism. So still going to be, right, causing a decreased bone density, but this is due to overactive parathyroid glands, hence in the name, hyperparathyroidism. You'll get more into this in the endo thing, so I'm not going to belabor this particular slide. You can read that on your own. If you have questions, let me know. But the biggest thing with this one is what ends up happening is the metatarsals start almost kind of eroding a little bit. right? This is what hyperparathyroidism will do. So, why do I show this to you? Because again, hey, I slammed my hand in the car door, X, Y, Z, whatever. I'm here to see because I have hand pain, right? Okay, well, there's no fractures, but what the heck is going on here? I want you, boom, I gotta wear some labs now, right? This is where like radiology, what do we do? Well, we're looking to find things, but then we're also looking to give us clues potentially of something that may be going on underlying that we didn't even know about. Because why would I order a parathyroid lab, which you'll learn junior semester? You don't order parathyroid labs on everybody. That is not a standard screening lab. It's not something that you normally do unless you have a reason to do it. One of the reasons to do it is an x-ray that has these erosions that are kind of sitting a lot of times in the middle phalanx, but primarily in the hands is when we see it. That's it. That's just really kind of a teaser. If you see that on x-ray, this is one of those slides you want to kind of keep for your clinic to go, hey, that's weird. I think I had one of those. Then you go, okay, let me order those and no labs, which you'll learn next semester. Not hyperparathyroidism, I will not test you on. Rickets, I will. Okay. Not really a big deal here in the United States, but I would argue that probably about 70% of this class at some point in their career is probably going to deploy or do a tour somewhere where this is a big deal, right? And you may end up seeing this when you're working in the community. And actually, for those of you going to the civilian sector, if you work in rural areas, right, or impoverished areas, you may see this here in the United States as well. So biggest thing is the bone fails to mineralize is the vitamin D deficiency, right? That's what rickets is. It's a vitamin D deficiency. It is most common in Asia and the Middle East, mainly because that's where a lot of our third world countries are, right? And so they don't get a whole lot of vitamin D in that area. There's dependent, resistant, and secondary. I don't care about that for this course, okay? I care that you know that it's young people with a bow-legged appearance. X-ray is your initial study. And the findings that are consistent are looking at the cupping, the fraying of the metaphysis, which is another word for the growth plate area, okay? Here's normal, normal, abnormal. The biggest thing is instead of the cupping and fraying, right? It almost looks like it has like this fuzzy appearance. Like it's not, I don't have well, clear, defined growth plate, right? Diaphysis, epiphysis, metaphysis. If I follow my cortex, it's right there, nice and defined. And then I come over here and I'm like, well, where does one end and where does one start? On top of that, I have this bow-legged appearance, primarily in the femur. It can be in the tib fin too. Be careful with looking at x-rays in kids who are bow-legged in the tib fin and going, oh my goodness, you have vitamin D deficiency, you might have rickets. Because another thing that can cause bow-leggedness in children is kids who are advanced and walk before 1 year old, right? Because their bones haven't fully hardened yet. So having that weight on kids, if anybody has kids and they started walking before 1, you might end up bow-legged around the tib fib area. That's normal, right? Because their femurs are pretty well to handle the weight, but their tibia is not quite there yet. So that's why I say when I'm looking at rickets, I'm looking more at the femurs to make sure and compare the two. I don't want to just look at tib fibs and be like somebody has rickets, okay? Here's another fraying of that distal femur. So how do I look at the fraying and go, how do I know that's fraying? Well, again, look at how clear the cortex is on my normal, referring back to my normal. Look at my the beautiful, bright, light gray, whitish line right at the end of the tibia. But here I don't have that. I don't have that on these guys. Right? I can see where the bone ends, but there is no clear cortex, and it's kind of fuzzy and it looks like it's fraying. Okay? If you get a really good x-ray, that scalloping up at the top, you see the scalloping on the inside of the cortex, right here. It's not a nice straight line, it has kind of like that little curve cut out there. That's a super advanced finding, right? Don't get so hung up on that, focus more on the fraying of the joint space, the vitamin D deficiency, the bow-leggedness, the bowing of the femur, okay? Going back to this slide again, it's going to be in kids. So if I give you an adult x-ray and rickets is an answer choice, it's an adult x-ray. Don't choose rickets, right? It's the pediatric thing typically. Most common cause in Asia and Middle Eastern children, young people, bow-legged appearance, x-rays the initial study. There's your normal compared to your abnormal. Good? Yeah, please.
It's an advanced finding to find, like, to look at the scalp, meaning like it takes advanced skill, or it's
Advanced
more.
skill. I
Okay.
mean, look how magnified that is. I would not expect you guys to pull that out. Yeah, yeah, good question. Because here's the deal, if it's that subtle, right, you probably have other things going on that will lead you to believe rickets, right? You'll learn more about rickets and peds, but like delayed growth, right? You're gonna have other kind of factors that are gonna lead you into it. Their lifestyle, their community, that kind of thing, they're not getting the vitamin D, so I'm not too, it's more of an advanced finding. If I give you something like this, it's gonna be designed over the frayed growth plates. Okay. Good question. Okay, osteomalacia. So what this is defective bone calcification after growth plates close. If it's after growth plates close, what population of patients are we talking about? Adults, not peds. If you get an x-ray and you have some growth plates in here, which we'll see some later on, it's not osteomalacia, okay? So, what happens? You have increased osteoblast activity. Osteoblast, bone, right? Good. You end up with anorexia, weight loss, muscle weakness, and bone pain. The reason you have the anorexia and weight loss is just because everything hurts so much. Like they don't want to eat, they don't want to do anything, like they're not, right? It's counterintuitive. People are like, well, if I'm not doing stuff, then how am I losing weight because my bones hurt, right? You know, bones need weight bearing in order to grow, in order to do that. So it hurts to do stuff, so they just kind of chill in that aspect. X-ray's the initial exam. Usually it's skull, spine, and pelvis, okay? And the key thing to this one is, look at the top. This is my abnormal. It's these weird transverse lines that are coming across all the areas, right? These more radio-opaque transverse lines that are coming across all of the areas of the pelvis and the femurs. And notice that fractures are what? Are fractures more radiolucent than the surrounding bone or more radio-opaque? More radiolucent, right? So we got a break in the bone. Why do I have these radio-opaque lines, right? They're not fractures. This is signs of osteomalacia because of the increased osteoblast activity. Okay? Right here, all these horizontal lines coming across, right? See what I got on the next slide. Okay. That's what I need you to know for this one. Horizontal lines across the pelvis, radio-opaque lines, not radiolucent lines. If you see a horizontal radiolucent line on the image, that's a fracture. Okay? This is the only one that we had radio-opaque horizontal lines, particularly in the pelvis and the femur. This one is very surface level, which means there's probably not going to be a super involved question on it. If there is a question, it should be very straightforward with the stuff that I just said here in class. Sir? So right, so the condition causes the radiolucency because the bone is softening, right? It's osteomalacia. But the telltale sign on x-ray is noticing the radio-opaque horizontal lines across the pelvis and the femur. Thank you for asking that question so I can clarify it better. This is a condition that causes generalized decrease in bone density because the bone is softening, right? You'll learn this a little bit more than it is in HEMONC, but how can you tell the bone is softening on an x-ray? That's really difficult to tell. So the telltale sign to notice this disease disorder is those radio-opaque lines because of the increased activity, trying to fix it, but it can't fix it because the bone is softening. Yes?
Are you going to be giving us pictures of like a skull or the spine and trying to decipher what this is on skull and spine?
If I haven't provided you a photo to recognize it, I probably won't. So for this, no. If I give you an osteomalacia question, it'll be a pelvis, because this is really the most common area. Good question, thank you. If I give you an osteomalacia question, it'll be a pelvis x-ray. Okay. won't be this x-ray, but it'll be a pelvis x-ray. There's no pictures from the slideshows in the test typically. Go ahead.
The ratio of the bone mineral
The softening. I'm not going to get too much into the pathophys of this. I'm not going to get too much into the treatment of this because that is beyond this course, right? Right now, I just need you to notice it and know that if I see that this is a concern, you will learn that in further courses. But what this does is just prep you to go, okay, I can recognize it. Now I just focus on learning how to treat it and learning what the pathophys is behind it. Okay. Focal decrease in bone density. Which one is underlined and bolded? Osteomyelitis. That's the one that is testable. So just briefly as we run through, localized osteolytic metastases. Okay, so now we got cancers again that we talked about before, but this one is osteolytic, so there's still metastases. A lot of the same symptoms as the osteomalacia, but I'm not testing you on this one. But x-ray is still the initial exam, okay? What you end up seeing is basically eroded bone. That is not the bone, I mean the bone is missing, but this is actually a big mass from the metastases. Normal, white arrow, abnormal, bone missing. Right, that's it. Multiple myeloma, again, just touching on it, you will hit this more in HEMONC senior semester, okay? Malignant proliferation of plasma cells, right? Conventional radiology, so regular x-rays, will notice the lesions, okay? And skeletal survey is a study of choice. So what is a skeletal survey? A skeletal survey is basically an x-ray of every part of your body, from head to toe, right? It's not one x-ray, it's a bunch of x-rays, because we can't get it all on just one, right? And so they will x-ray everything, because when you have multiple myeloma, they want to see where all those lesions are. And so you will get skull, facial x-rays, cervical, all the spine, like every bone will be x-rayed when you have a patient who has multiple myeloma, right? Because here's what it looks like. This is very painful. This is not an asymptomatic condition. This is extremely painful. Normal forearm. We'll get more into details in the anatomy when you actually look at actual forearm stuff. And you can see all the lytic lesions within the bone there, right? Multiple myeloma. Not going to test you on it in this course, but you need to see it. So when you get the HEMONC, you'll be like, oh, I remember that. Okay, so there we go. Osteomyelitis, this one we do need to know about, okay? So typically caused by a bacteria. Most commonly, Staph aureus is the cause in pediatrics, okay? What ends up happening is usually there's a fracture. Usually it's an open fracture. It's an open fracture that wasn't realized it was an open fracture, so they never got antibiotics. Bacteria got introduced due to the injury, right? And then the bacteria proliferated, grew, and started eating away at the bone. That's what the osteomyelitis is. Symptoms, right? Usually within 2 weeks. This is painful, okay? This is not typically an asymptomatic thing. It starts to cause significant pain. You're gonna have fever because there's an infection, pain at the site where there's issue, probably warmth and erythema. Like everything's gonna tell you there's some kind of infection going on. I'm not really sure what it is, but something's going on there, all right? You're gonna do the x-ray. X-ray can be normal for the first couple of weeks. So why is that on there? Like, well, why is it normal? Because what might happen is a kid might have fallen, or might have been hopping a fence or whatever and took a cut or fell and kind of fractured a little bit, right? Had a small line fracture, but also had a cut in the skin. Maybe it wasn't a whole bone popped out and popped back in, but just like a little thing where I had like a hairline fracture and I also fell and got a cut to my skin, right? That opens into the ear, that makes it an open fracture, even though it wasn't the full-on like bone sticking out type fracture. Bacteria can't get in there. So they come in and you kind of look at it and you braze over the fact that there's a scab there from like 3 days ago, right? You get the x-ray, you see a small hairline fracture, and you're like, ah, you're fine, don't worry about it. That x-ray can be normal for the first 1 to 2 weeks, means you might not even have seen that hairline fracture. That's why still the answer is, hey, If it's not improved in 7 to 10 days, come back so we can redo the x-ray. Because hairlines might be hidden by swelling or soft tissue or something along those lines. So we want to make sure we do the x-rays first, normal. MRI is the study of choice, much like the avascular necrosis, because again, we're looking for deteriorating bone, dying bone, okay? This is what your osteomyelitis starts to look like. Normal on the left, abnormal with a big red circle sign on the right, and you can see what's happening is that basically the bacteria here is just eating away at this bone. It's causing it to deteriorate. Most of the times this happens in the joint space. It doesn't have to, but it's just really easy for the bacteria to find themselves a little area in that joint space and house and multiply and then start to grow and cause those issues. This is why any patient with an open fracture gets antibiotics. Any patient, to prevent this from happening. Because once this starts, I can't fix this. I can't bring that bone back. Right? If you catch it early enough, maybe they can do surgery, maybe some of it can grow back, but this is already too far gone. Like, this is not going to be a good day for them. They're going to end up having significant degenerative arthritis, have issues with that foot for probably the rest of their life, pain with activity, that kind of thing. Right? The bacteria starts to eat away and destroy the bone, usually Staph aureus. Almost always Staph aureus. Why more kids than adults? Because, well, at least back in the day, not so much anymore, but kids are always outside playing, falling off trees, falling off fences, stuff like that. They just hurt themselves, mom and dad don't bring them in, and maybe something. They had like a small fracture, you had bacteria introduced, and we end up with osteomyelitis. Sometimes you can get this post-surgery if the surgery was not sterile, right? But most of the time post-surgery, you're on a certain level of antibiotics afterwards just in case to prevent infection. So it's more rare in that area, but it can actually happen. But mostly peds, and that's the concern. So again, open fractures, antibiotics. Questions on osteomyelitis? Going back to that slide, just that way you can look at the symptoms, right? You can have an idea what it looks like. You know the initial study, you know the study of choice. Remember, this course is all about finding abnormalities and also knowing what to order once you find them or you suspect them. Okay. We just covered all those. Generalized increases in bone density, the one that I need, generalized decrease, osteoporosis and rickets and osteomalacia. Those are the ones I need you to kind of know about. Don't worry about hyperparathyroidism. And then the focal one's just that osteomyelitis. Questions on any of those increases or decreases in bone densities? All right, go ahead, take 10, come back to the top of the hour before we jump in. Really good questions on the break, right? I love that. Any questions? I did the same thing. I sat and I waited to break. It's okay. Okay, so I want to clarify some stuff, right? So we were talking about the avascular necrosis. I had some really good questions, right? So understand that the avascular necrosis, we were talking about that sclerotic area, that increased density, right? This is what happens when you miss scaphoid fractures, okay? So when we do the x-ray, it's normal. And they come back in a week to 10 days and I do the second x-ray. I'm not actually looking for avascular necrosis. I'm probably not going to see that sclerotic lesion after just a week. But what stands out more is that scaphoid fracture. We're going to talk about it more when we get to the upper extremity stuff, right? So what I'm looking for is, does the fracture within the scaphoid show up more after that 1 week? As soon as I see that, they get the ortho referral because they need to be evaluated for surgery because we're trying to prevent avascular necrosis. The pictures I'm showing you that actually show the sclerotic areas and the avascular necrosis, these are scaphoid fractures that were missed, and that's what it leads to. Is that track, okay? So I'm showing you the advanced x-ray, so if you see an avascular necrosis, you know what it looks like. The goal here is that you guys can pull out the scaphoid fractures either via the repeat x-ray or the MRI as that study of choice to be able to get a hold of that patient before the scaphoid starts to necrose and you have the avascular necrosis. Okay? So when you're going on radiopedia and you're looking up these scaphoid fractures, you may find fractures on there that don't have that sclerotic area. It's because these were fractures that were caught prior to the avascular necrosis happening, because that takes time to happen. That's good news. That's what you want to find. Okay? All right. This slide here, words are important. Know your population. Know their education level. Because I've had this statement made to me before. Because they went to an urgent care. And they got the x-ray, they followed up with me, and this is exactly what they said to me. So when I saw this on the Google, I'm like, oh, I'm gonna use that. They're like, no, it wasn't broken. I'm like, oh, that's good. Like, yeah, they just said it was a small fracture. Let's have a conversation. So anyways, all right, so vocabulary. Woo, look at all that stuff, right? We're gonna go over each of these words. This is just a nice, fine area for you to have definitions of everything. We're gonna cover pretty much most of these throughout the rest of this lecture. So what are we going to do here? Now we're going to start recognizing dislocations and subluxations. Different words mean different things. Okay? Words matter. We're going to recognize fractures, describe fractures, talk about a little bit of joint disease, and some lesions. All right, so recognizing dislocations and subluxations. Okay. Over here on the far right, is this dislocated or subluxated? So, dislocated, okay? Dislocated. Subluxated is when it's shifted, but it's not all the way off of the joint. We're going to see some subluxing here in a second, okay? If I gave you just the AP right here, can you tell me, pretend this isn't here, can you tell me whether or not that is anteriorly or posteriorly dislocated? You cannot. You need the lateral, because your eyes will play tricks on you. I will tell you, for me, and I've been doing this for almost 20 years looking at x-rays, this looks like it's anteriorly dislocated to me. It looks like that the femur is lying over the tibia and fibula on just this AP. That's what my eyes are telling me. Some of you may see it the other way around, but then when you get in the lateral, you realize, oh, whoops. It just depends, and we'll talk about how to name this here in just a little bit. But here's your normal. This is where the knee's supposed to be, right? And this is why we say joint spacing and joint alignment. This joint really not aligned, right? This is a problem. The patella's doing good. That's nice. It's stable where it needs to be, right? That's nice of it. Here is a subluxation. On the thumb. See where the thumb sits right here? I'll talk about this pen here in a second. This is normal. This is normal. Okay? See the nice alignment. And now look at the shift. Right? Not sitting where it should. Sublux, partially shift, but not completely removed. Okay? Dislocated, completely removed. Sublux, partially removed. Dislocated, completely removed. Sublux, partially removed. Right, we just covered that. Okay, now let's go back to this one. We're talking about this dislocation, subluxation. Sorry, I promised you this. That pen, don't worry about that. This patient basically had pain in this region. So sometimes on x-rays, the tech is really nice. They will put like a little pointer or put a pen there so the radiologist knows where the pain's at. They'll ask just in case your history just said hand pain, right? And they'll ask the patient, they'll be like, it's right here. So they'll do that. So that's not pointing out an abnormality. That's them telling the radiologist, hey, this is where they hurt. Okay, all right. When we name dislocations, we name them for the distal fragment and the direction that the distal fragment is from the rest of the body. Okay? Wrap your mind around this. It's not based off of, because here's what you don't know, right? What moved? Did the femur move? Or did the tendon move out of place? I have no idea, right? So we had to come up with a naming system so everybody speaks the same language. Because I don't know which bone actually moved from where it's supposed to be. I can't tell that from the x-ray. I wasn't there when the injury happened, right? So we name it for the distal fragment of where it's at compared to the other part of the body. So the distal section of this is what? The tendon. So the tendon is what in comparison to the other bone? Anterior. This is an anterior dislocation. Don't get tricked. Because you're going to look at the femur and be like, oh man, that's posteriorly dislocated. Stop. What's the distal fragment? And think anatomic position, guys. So when we get to the forearm, if there's dislocations in the elbow or dislocations in the wrist, right? Distal fragment is how we name this, no matter where it's at in the body. Same thing with subluxations. Now, we don't use medial and lateral in the hand because that's confusing, right? Which way's medial, which way's lateral. So when we're naming things in the hand and the wrist, we use ulnar and radial. Make sense? Ulnar and radial in the hands and the wrist, because of the fact of I don't want it to be confusing. In medicine, we want to try to be very clear. If I'm talking to you and you're talking to ortho, you want to be speaking the same language. The ulnar and the radius don't move. They stay where they're supposed to be. Even if I flip this, right, they stay there. So which way is it going? Okay? So use ulnar and radial instead of medial and lateral. We'll see more subluxations later on, and we'll have you guys kind of name them in that aspect. So just remember, distal. So when the hand is like this, you're naming it for the distal fragment, right? Don't think distal is always down here. Anatomic position. These are the distal areas of the hand and the wrist. But the x-ray is always going to look like this. But this is the distal area, so just remember that when you're naming things, okay?
So that,
Yeah.
so that one would be a first digit ulnar subluxation?
So let's take a look at it here. So which bone is this going to be here? Radius. This is going to be your ulna, right? So if it's shifted this way, right, towards the ulna, and we're looking at the distal, right? So then yes, I would say that this would be a ulnar subluxation of the middle phalanx of the first digit. Yeah. Good. So take your time, run through it, right? We're looking at it, trying to figure out which way are we going in that aspect. Always for the distal segment. All right, so the difference between dislocation and subluxation, partial versus full. Right? If there's any type of contact still in that joint space by those two bones that create a joint, right, then it's a subluxation. They're completely separated, it's a dislocation. And you can't fracture a joint. People are like, I broke my knee. You didn't break your knee. You broke your tibia, or you broke your femur, or you broke your patella. You can't break a knee. A knee is a joint. You can dislocate a joint, but you can't break a joint. Right? Broke my elbow. No, you did not. All right. So now we're going to start going through, starting to finally break down and find fractures, right? We briefly talked about it, kind of went through some stuff. You guys saw the changes in density, but now we're going to go into fractures. And now we're going to talk about some of the stuff that some of you pointed out on me on the x-rays. So some of you came up and showed me these foot x-rays and be like, hey, what is this radial opaqueness here? Some of you are taking that next level and are already starting to notice abnormalities in the x-ray that don't look like the rest of the body, right? So good, but some of these are normal findings. So these are sesamoid bones. We see them commonly in areas of high friction, usually the first metatarsal phalangeal joint. You sometimes will get them in the first metacarpal phalangeal joint as well. Okay, you get these sesamoid bones. They're kind of sitting on tendons. and it's just areas of high friction. So what happens is the body doesn't like the inflammation and the friction, so it tries to protect itself by creating this nice little sesamoid bone. They're normal. You don't gotta do anything for them most of the time. Some patients, they'll get inflamed and angry called sesamoiditis, right? And you'll have to kind of do like a little steroid injection or something to try to help calm that down. But they're very, very normal. They are not a fracture. Okay? Question on sesamoids. Some body parts have extra accessory ossicles. This one in particular is in the shoulder. It's an ossicromial. So we have our humeral head. Okay? Got the clavicle coming in here, and this should not be there. But it's a normal variant. Okay? So, right here, normal variant. If I see this on an x-ray, not now, but when you guys get more into it, when we get through it, and you look at the shoulders, you know what a shoulder x-ray is supposed to look like, then you're like, that's not supposed to be there, right? Is that an abnormality or is that a normal variant? What do you think is the best way to figure that out? Compare. How am I going to compare it? What if I don't have any previous x-rays? Radiopedia. No. Good try. Okay. Never had any issues before. This is a right, let's say this is a right shoulder x-ray. What else can I do? Order on left shoulder. The odds are, if this is a normal variant, they're going to have one on the left side as well. Compare like body parts on that patient. Most patients that have these additional accessory ossicles, even the sesamoids, but especially the ossicromial, will have it on both sides. If they have it on both sides, it's a normal variant. Right, so I'm doing right shoulder pain, get the x-ray, what is that? I'm going to order the left side just to make sure. All right, and then this one here, we'll talk more about non-unions later. So what this is this is a scaphoid fracture that did not heal back together. So how do I know it's a non-union? Well, one of the things I can look at, it almost looks like two separate bones. I have two full cortexes all the way around both pieces here. Right there, right? And also timing matters. We'll talk about non-unions with timing more specifically a little bit later. But this is where they come in and you get an x-ray because they hurt their hand or whatever, and you see this and you're like, oh, have you ever hurt yourself before? Oh yeah, I had a scaphoid fracture in the past. Okay, cool, it's just an old fracture. I don't got to act on that here today. Mainly because I got full cortex all the way around, and they probably won't be tender in that area anymore. Here's a nice little chart to try to figure out acute fracture versus sesamoid versus old fracture. Biggest thing between the acute fracture and the sesamoids or even the old fractures is sharp and jagged versus smooth. Right? It's gonna be that break in the cortex. All right? Is there a cortex all the way around it, like I just showed you on that scaphoid? If the answer is no, that's a new fracture. Right? You won't have that bright whitish line kind of around the new fractures. Your sesamoid and accessory ossicles, bilaterally symmetric, almost always. Right? So that's what you're going to do if you're like, hey, is this the normal variant? Let me get the other side and see if it looks the same. We are created fairly equal left to right as individuals when it comes to most of our anatomy, right? So they're trying for you to kind of run through those things. Fracture healing. First of all, is this pediatric or adult? Do most adults have this large of a gap in their elbow? That's a knee trick too. Do you see a patella? Right? So this is the pediatric. This is the pediatric. So this is a younger one. This is much younger, right? This is why I say this is a perfect example of why I say, like, I'm not going to expect you to fully interpret pediatric x-rays, because where the heck are the growth plates? They're not there yet. The epiphys haven't formed yet, right? Pediatrics is tricky. Now, in the grand scheme of things, you're going to know if it's a pediatric, because hopefully you ordered the dang x-ray, so you saw the kid first, right? But this is why when it comes to like fractures and stuff like that, I'm not throwing pediatric x-rays at you because they're tricky. Right? There are no epiphyses in here because this kid is too young. They haven't started to form yet. Right? But what this is meant to show you is to show you the periosteal reaction between fracture healing. Okay, this is the same patient that they kept taking pictures of. Fracture here, it moved just a little bit, but then we start to have that periosteal reaction. We can start to see the periosteal reaction in kids at day 7 usually. All right, that's the bone trying to heal together. Here's 2 weeks, look how quickly this is healing, right? And 6 months. You wouldn't even know there was a fracture there. Adults, it's not that fast. The older you get, the slower it takes, right? But just to kind of show you how you can trace this yourself, right? If it's your patient. First picture, I would still send to ortho and be like, hey, do you guys need to see this? They're probably saying no, probably not. On day 4, they were like, we'll do another one in a couple of days to see how it's doing. And then here they probably aren't seeing the kid anymore. You're gonna keep an eye on it. They just keep doing the x-rays, right? They'll be in a cast, obviously, this whole time, and you see how quickly it heals. So just see that stepwise process. That periosteal reaction can pop up on an x-ray, right? And sometimes that's the sign. It won't be this obvious, right? But sometimes we'll see some fractures here in this course to where you're following the cortex, and then there's like a small little kind of bump, and following down, that's a sign that maybe there was a hairline fracture there that wasn't seen on x-ray, but it's healing, right? Because you have a small periosteal reaction, like right in here. So we'll take a look at more of that. Here's an adult one, right? This patient obviously needed surgery. But look at the difference between 2 weeks and 6 months here. Look at the 6 months, we're still not healed yet, right? We still have a lot of periosteal reaction at 6 months. You can still kind of see a little bit of a fracture line there, here, right? Still trying to heal up, okay? This guy will have the rod probably for the rest of his life. Femur fracture. How do I know this is a femur and not a humerus? Anatomy, there's my lesser trochanter. There's my lesser trochanter. Can't tell if it's left or right. Well, I can because they put a little left marker right there. So, question?
Are they hollowing out the medullary bone when they put that?
Yeah, they do not. So I've been in on some of these and like the hip replacements and stuff like that. And so they don't. They start the drill, right? To start kind of like the hole, and then it's hammer in. Like, I mean, it is violent. When you're in ortho, it's like you get a chance to see like a total hip replacement or something like this, go. You don't have to spend all your time in surgery because clinic is what's more important in phase 2. But if one of these pops up, go. Because these are violent surgeries. I mean, you should see that the surgeon is putting all their weight in, the whole body and table is moving. Yeah. Yeah, it makes me go, I never want that. Like they are violent. So they start it, and then they just, because the medullary bone will break apart pretty easily once you start it. So they'll start the drill, and they'll begin it, and then they just go straight through. Yeah. All right, so how do we recognize it? So here are some signs of an occult fracture. What's an occult fracture? It's like that hairline, right? That one that's not really obvious, doesn't kind of jump out. So here are some of the signs you can see that. So soft tissue swelling, right? We'll look at that on the x-ray. You got to look at our soft tissue. Blood in the joint hemarthrosis, specifically in one area, and that's the elbow. We'll talk about that, right? You can see no fracture, but there are signs that there is blood in the joint in the elbow, and you'll see what those signs are that will tell you that there's a fracture there that you can't see. We already know that fracture lines tend to be a little bit blacker or more radiolucent than the other lines. The abrupt discontinuity of the cortex, we talked about that, okay? And then the periosteal reaction, that 10 to 14 days is like a generality, but as you saw, there can be many factors to that, right? Kids, it starts a little bit sooner. Adults, it might take a little bit longer. What's the blood supply, all that. I don't need you to memorize the 10 to 14 days. Just know that these are the signs of an occult fracture. I'm not testing you on this, but this is important for your clinic to know which patients you need to give more time to. Some you're going to say 6 to 8 weeks if you be feeling great. Some you need to say 3 to 4 months. It just depends. This is just meant to show you who heals faster and who heals slower and why. Okay? No test from that chart. Okay, minus the big yellow arrow. I want you to take a second here, go through your normal, look and see what normal is, and then go through your abnormal, and if there's anybody here who thinks they see a fracture, let me know. Just by a show of hands. I'm not going to call you up. You're going to say, show it to me. if you think you see a fracture, and you think you found it, raise your hand and let me know. I'll give you about 30 seconds or so. Got a couple? Okay, all right. So I'll give you another few seconds to run through it, and then I'm going to run through it with you. Okay, so at first glance, I would say, hey, maybe we don't see one. But then you see the giant soft tissue swelling, and it makes you go, I'm going to look a little more, right? I want to double check it. So if I follow my cortex down, I don't see a whole lot. The cortex looks pretty good. Cortex, that's shadowing, that's the tibia coming into the fibula. It looks pretty good there as well. So for over here for you guys, cortex looks good. Coming through here, looks pretty good. All right, I look at my talus. Looks pretty good. Then what's next for me? I go into my medullary canal. So I'm going to go into the fibula first. Not too bad. Oh, what's that? What's that? We saw this in the tibia. Good. Good. And you're going through your stepwise process. Look at how subtle that is. Look at how easily that is able to be missed, right? Subtle radiolucency in that medullary cancellous bone area, right? So at first glance, easily overlooked. But when we go through our signs, let's say you missed it, right? You go through your joint alignment looks good, joint spacing looks good. Now I trace my soft tissue. Whoa, why do I have that? Let me go back, I might have missed something. Now this could just be an ankle sprain, but it makes you go back and double check again with more detail. So there's some very subtle fractures in the medullary area there. That's what's causing that swelling. Good. Here is the elbow. This is what I was talking about here. So I want you to focus on the normal one first. Now this one, use your screens because it's closer to you, and you might have to zoom in just a little bit to kind of figure this out. So, taking a look at stuff, we have what's called an anterior fat pad here on the normal, okay? Does everybody see within the soft tissue right up against the bone, this slightly radiolucent area? It's probably easier to see on your screens than it is on the PowerPoint up here, okay? Small, a little bit darker than the rest of the surrounding tissue, okay? Now, when I look posteriorly, does anybody see any radiolucently on the normal posteriorly? I hope not, because I don't. There's nothing there, okay? It is normal to have a radiolucency on the anterior side of a normal x-ray for the elbow. That's your anterior fat pad. That is thicker. It's normally seen. That is okay. Where the abnormality comes in is two things. One, the shape of the anterior fat pad. You can see it comes out more, right? That radiolucency comes out more. It looks like a sail on a ship, as opposed to just this little area here. But then more importantly, where the white arrows are, that posterior fat pad side. You see how it's got that radiolucency there right in the back part of the humerus that's not on the normal, okay? What that's from is from blood from the small fracture, because it's such a small area, putting pressure on those fat pad signs, so it pushes it up. So it makes that anterior one kind of balloon up like a sail, because it kind of pushes it, but then more importantly, it pushes the posterior one up more and makes it visible. Anterior fat pad sign is normal. Posterior fat pad is never normal. You should never see a posterior fat pad on an x-ray. If you do, there's likely a fracture in that elbow, more commonly in the radial head, and I have it arrowed because look at how minuscule that is. So do I expect you to pull out that fracture on an x-ray on the exam? Not something that small, but if you saw the posterior fat pad sign, you know there's a fracture, right? Pulling out the posterior fat pad sign is important. Most commonly in the radial head when you see these things, usually minimally displaced, this guy's going to be in like a sling for, a couple of weeks, maybe a cast, depending on what ortho wants to do, but for the most part, they're not going to do anything for this. But most radial head fractures that are subtle, you will find, not because you see the fracture, but because you see the posterior fat pad. That is that sign, hemarthrosis in the joint. Only in the elbow that we can do this. So even if you don't see it, if you see that posterior fat pad, there is a fracture somewhere in there. Treat it as such. Questions on that?
Just to clarify.
Yeah, please do.
This is only an elbow.
Only in the elbow. These fat pads like this is only an elbow thing. Correct.
The hemarthrosis.
So you can have hemarthrosis in any joint, but you can only use it to diagnose a fracture you can't see in the elbow because of the fat pad situation. Right? So any fracture, any small, minimally displaced that I can't see well fracture is going to cause hemarthrosis in the joint. Right? But think of all our other joints. Shoulder much bigger, knee much bigger, ankle much bigger than the elbow, right? And it doesn't have those fat pads, so it's just, you're not gonna notice it on an x-ray. You're not gonna notice a small amount of hemarthrosis on an x-ray in any of those other joints, because of how large they are. There's more area for that fluid and that blood to go. There's not a whole lot of space in here. So it just pushes that fat pad up, and that's what makes it noticeable. This is only doable in the elbow. Good question. Other ones? Okay. All right. Here's some periosteal reaction. This is what I was talking about here, right? So, got your normal again, pediatric or adult? Yeah, it says it right there, pediatric. But look, Pipsies, snowflakes. But primarily, I don't really see a fracture. Like this is two different legs, right? Because you always compare with kids, you always get bilateral just because you want to compare. But I don't really see a fracture in this fibula. I really don't. Maybe if I could score, maybe, but that cortex looks like it's pretty well connected all the way down. But then look at 2 weeks later, I have a periosteal reaction, which means there was some kind of hairline fracture there that just wasn't noticeable. Now, is that a big deal for the kid in the shaft of the bone? No, not really, right? But mom's probably bringing them back in 2 weeks because they probably still hurt a little bit, they're still limping, and then you do it, and you turn around and you go, oh, there was a small hairline, but it's healing well. I can see the periosteal reaction there. Nothing we need to do about it. Just continue to watch it. If you're limping or taking your time on, that's fine. I mean, it's not going to displace or anything like that, so you just tell mom to be careful. But this is how you miss a hairline, not because you were bad at reading x-rays, but just because it wasn't there. And then 2 weeks later, you see that periosteal reaction. This is going to be more common in your, I hurt myself, went to urgent care or the ER. They said to follow up with you in like 2 weeks, right? And then you come in 2 weeks, and then you find the x-ray. They're like, I can't believe they missed it. No, they didn't miss it. It wasn't there. Now we just see this. So, cortical irregularities. When you trace that cortex, you're looking for any gaps in the cortex. Normal. Ooh. Normal. Right there. This is the fracture right here. You see that? Right? If you, again, don't take it as a whole. Don't look at this and be like, oh my goodness, there's so much going on here. What can I figure out? Do it step by step. Follow all of your cortices first. Oh, I see that. I'm not stopping there because there might be more going on. But I definitely recognize that one there. Well, okay, moving on, because I can see that black line shouldn't be there. And even if you like, yeah, compared to this bone, right? But like, you look at all these other bones, you don't see any black lines through any of the cortices, but then there's one there. So it's another way you can use the same body part to kind of help you have these things kind of jump out at you. Then you go through your medullary and look, that all looks pretty uniform compared to the normal. Joint spacing and joint alignment looks good. Okay, we have a radial head fracture. Okay. For a little more obvious for you guys. Okay? This is normal because it's pediatric. That's not a fracture. How the heck are you guys supposed to know that? So I'm not going to test you on that kind of thing. This is a bad day. This is going to need surgery probably. It's a kid. They might just straighten it and split and put it in a cast. I don't know. That's a question for ortho next semester. But yeah. Okay. Moving on. Complete fracture. All right. Incomplete fracture. Complete fracture, all the way through the bone. All the way through the bone. Incomplete fracture, partially through the bone. Partially through the bone. Not all the way through. Okay? There are two types of incomplete fractures in peds. that are only in peds. Why do we have these a lot in peds? Kids are bendy. Kids don't like to break. Things are still soft. They're bendy, right? So, what we have here is a green stick fracture. Why do we call it a green stick? If you think about plants, right? You go take a stick, an actual like stick off a tree that's brown and kind of dead, you break it, it snaps in two. That's what we do, right? Kids, if you pull off a fresh leaf and its actual stem off of a tree and you try to break it, it doesn't break in two, right? You'll break the cortex or the plant wall, but the other side stays intact and it kind of bends. That's why it's a green stick fracture. One side of the bone bends and there's a fracture through the other side. We'll talk about torus later on. I don't have this picture up yet, so we'll talk about that later. But this is a green stick fracture, okay? If you have one in adults that's not all the way across, that's called a nightstick fracture. We'll have that later on, because why and how does that happen? Well, yep, exactly. The old-fashioned cops used to have the nightsticks that come and hit you. You put your arm up, it hits your forearm, it fractures it, but not all the way through. Nightstick fracture. The difference in adults and kids is two things. One, growth plates. Two, bendy versus not bendy. The adult bone will still be straight. It won't be bent because it just took the impact, right? And didn't fracture all the way through. This, the kid likely fell, went bendy, fractured part of that, and that's not all the way through. So green stick fracture in kids. Here's the torus fracture, named after the old Roman columns and Greek columns. Because what happens is, they fall, again, they're bendy, they don't break all the way through, but what they do is they compress part of the bone and it bulges out, the cortex bulges out. This should be a nice straight line. Nice straight line. The cortex bulges, kind of like the bottom of a column. Okay? So you can't, you have to look behind right here. Look behind and you can see it right there. Because they're overlapping, right? So the bone comes down and whoop, it's right there. Do I need the second one diagnosis? I don't, because it's right here, right? We always get two to make sure we can kind of look at it from different angles. But yes, right there. Nice part about toruses is usually you will find them on this regular AP image right here, this first one. They don't often, you know, it's not one that you often need this one to find it, but it's just showing you what it looks like in a while. So again, they probably fell, and you know, like whereas adults we fracture that skateboard a lot of the times with the foosh. Sometimes they just kind of compress and just, it's going to heal fine on its own. It doesn't need anything, but it is a torus fracture. Incomplete because it's not through the bone.
Question, is this only for peds?
Only for peds. Torus fractures and green stick fractures are only peds abnormalities. And how do I know it's peds? Again, I got my growth plates, So that's what I'm saying, like, if I give you peds x-rays, right, outside of Salter-Harris, I'm not looking for you to be able to distinguish between, is that a fracture or is that a growth plate, right? But within the shaft of the bone, that doesn't matter, peds or not, right? You're knowing that that's an abnormality there, right? Because this is too difficult for you guys to tell me if that's a growth plate or if that's just a fracture. Outside of Salter-Harris, which is fractures of the growth plate, but you'll know it's that kind of question because there's 5 types of Salter-Harrises, which means your answer choices are going to be the 5 types of Salter-Harrises, right? So then you'll know I'm asking you to look for a Salter-Harris fracture. So you know that there's something in there, you just have to figure out which one it is. Other than that, any of your ped stuff is going to be in the main shaft of the bone that doesn't really make a difference of seeing if there's a fracture or not for peds versus adult, except for the name, like you just said, torus or green stick. Avulsion fractures. These are things that can happen anywhere where a tendon attaches to a bone. Usually it's from a severe strain or sprain, right? The pulling peeled off a fleck of the bone. Sometimes it can be all the way off and be floating in the soft tissue. Sometimes it's just the fracture of the bone where the tendon connects. And so if I follow my cortex down, got that little line, got some bone there. So that's where I see the fracture, right here. Follow my cortex around, and there it is. Now, I'm not gonna stop there, I'll do the entire thing, but here's my normal. And that's what a avulsion fracture is. Is any area where it kind of got ripped off. Another way to kind of tell an avulsion fracture from just a regular kind of clean fracture is it looks like a puzzle piece, right? If I were to take this and kind of put it right back in there, it's gonna fit perfect because it was like just torn. It looks like it was just torn right off the bone. It's more kind of like jaggedy and weird. Like I can just put it right back in there. Those are gonna be your avulsion fractures. Most other regular fractures that aren't avulsion are nice and clean because they just kind of broke through. But this one was kind of torn away from the bone. Everybody see that? We see this a lot in the fingers. We'll talk about some of those specific names here right now. So mallet finger, okay? You'll talk about this more in ortho, but the mallet finger is basically when the extensor tendon ruptures and peels off that fleck of bone. Now you don't have to have the fracture to have a mallet finger, okay? And it's really easy to diagnose. You don't even need the x-ray to diagnose it. You get the x-ray to figure out if ortho wants you to have surgery or not. But all you gotta do is take their finger, which is gonna be bent, isolate it, kind of like you guys do those proprioception things, right? Isolate it and say, hey, straighten your finger out for me. I can't do it because the extensor tendon is ruptured. They can't lift their finger up. You just diagnose it without an x-ray. You still get the x-ray because some need surgery, some just need a splint. Ortho decides that, right? But this is your extensor tendon injury, your mallet finger from an avulsion fracture. As a different names for different things. What type of fracture is it? Avulsion. What's the injury? Mallet finger. What tendon's involved? The extensor tendon. So you can see where there's multiple ways of say, hey, do you know what this is? That could be asked potentially. So the opposite of that, jersey finger. See this a lot in your flag footballs, right? They go to grab somebody, they get the jersey, it pulls their finger back, and it ruptures the flexor tendon. There's a fracture. Pretty obvious one, like I mean it's a big fragment, right? They're not always this big, but just the opposite. You isolate their finger, you go, hey, try to flex down that finger for you. They can't do it. They can't flex down. It's a jersey finger. You've made a diagnosis. You have to make sure to isolate these two joints because you don't want them to do this because they can still flex the interphalangeal joint. They just can't flex the distal one, right? So, jersey finger, flexor tendon injury, avulsion fracture. So if I have a 25-year-old male that presents with the inability to fully extend his finger after a game of basketball, what injury did he likely sustain? Mallet finger. Good. I had to think about it for a second. But I wanted to ask you next is, what are you going to order to confirm that? X-ray. X-ray. Probably put him in a splint. So use the extension more than this because as I had to think about basketball, football, because this question used to be football for jersey finger, so I was like, wait a minute, I changed it. Okay, questions on that stuff? This is one of the more simple ones here. A pathological fracture is a fracture anywhere that goes through some type of pathology. That's it. Right? So, what is this here? If we see the medullary area, I have this area of radiolucency, right, in the bone. It's some type of bone lesion because it looks different than the rest of the medullary canal. I don't know what it is, but I have the fracture right here from the cortex that goes up and it goes into the pathology. So it's a pathologic fracture. Any fracture that goes through pathology of the bone is pathologic. It's a general term. Okay? I don't need you to know specifically what this lesion is. You know it's a pathologic fracture. So if there was a question that asked you to best describe this fracture, technically oblique, incomplete oblique is correct. We'll learn about oblique in a little bit. But the best description is pathologic fracture because it's through some pathology. If it looked like this over here, the normal, right, and it had the fracture, then an incomplete oblique fracture would be appropriate because I have no pathology to further classify it better. Stress fractures. You're going to see a lot of these, all right? Most of them aren't going to be seen on x-ray. So basically weight bearing areas, muscle forces, most commonly in the feet, tib, fib, shins, those kinds of areas. You can have them anywhere, but the lower extremities is the most common, all right? Deep ache, follow rapid training, right? Usually you're gonna see this, I don't know how often the Army does it, but at least in the Air Force, about every 6 months, right? That month before the PT test. How much you been running? Oh, I've been running regularly. Yeah, you go from nothing for 5 months, and then all of a sudden you're trying to run 3 miles a day. You're gonna get stress fractures. Usually you get the progression here is pain after activity, I rest, it gets better. Pain after activity, or pain with activity. Now, like, it doesn't hurt afterwards, it hurts while I'm doing it, right? That's the next stage. Then, now it just hurts when I walk, right? I haven't been seen for it, now just walking hurts, and then finally it hurts even when I'm just sitting there. Like, that's the progression. X-ray is your first, your initial study, but 85% of them can be missed. MRI is your study of choice. Technically, CT and bone scan can diagnose these. We talked about it briefly, right? But MRI is your study of choice, not those other ones. CT will still miss some. MRI will not, right? And a bone scan is that nuclear medicine study that's really extreme for a stress fracture. We're going to do an MRI. Do I need to do an MRI on most of these? If I can't find it on X-ray, should I jump to an MRI? The answer is no. Because what's the treatment for these? Rest, get better, and then gradually increase your activity, right? I can diagnose and treat this based off of symptomology and patient history and a normal x-ray without having to do the MRI. You do the MRI primarily going to be for your persistent ones, the ones that just aren't getting better, just to kind of confirm it and verify it so that way you know that's what it is, and it's not something else. The MRI is more used for, let me make sure this is just a stress fracture like I suspect, and there's not something else going on here that I'm missing, right? So, don't worry about when you're jumping from an x-ray to an MRI and this kind of stuff, just know which one's the initial study, which one's the study of choice. So if I give you a 25-year-old soldier who has increased their activity significantly from going to basic training, and they're having pain in their shin and their feet or whatever, and I ask you either initial study or study of choice, you know which one to go for. Look at how subtle, if you can even see it, because I barely can, this is on the x-ray. I have a big double arrow, so it makes it a little bit easier to look at where you're supposed to be looking for. But super, super subtle. It doesn't even go all the way through the cortex, guys. It's like not even all the way through that. Okay? But look at the MRI. Look at how inflamed and angry the MRI is compared to the rest of the bone, right? So that's why MRIs are study of choice. But again, we're not going to really jump to these very often. You need to know it's a study of choice. A lot of this stuff is just going to be your treatment that you're going to give the patient. Rest and gradually increase activity. Subluxed or dislocated? Subluxed. Which way? Over. Good. Good. Which joint? Fifth what? Proximal interphalangeal joint. What distinguishes complete from incomplete fracture? All the way through the bone or partially through the bone. Right? Incomplete is partially through, complete is all the way. And then the tendon creates holes and fractures. Right. You got this guy one, right?
Mm-hmm.
Yeah. Let me count how many lecture blocks we have left. 1, 2, 3, 4, 5. Correct? Fantastic. 5 lecture blocks. This and 4 slideshows left. Which means we will stop here for the day. See if this body have that many lecture blocks. We count 5 left, right? I want to make sure I don't overwhelm you guys with stuff.
Monday through Thursday next week.
And then Monday, following Monday, that's the lab though. So the lab, we'll briefly talk about the lab. The lab is used for 2 things. What's going to happen is I'm going to try to get one of the ortho instructors in here to basically just go over cases, right? Because most of the stuff is MSK for this block, just to get you an idea of thinking like ortho does, right? Thinking of how to read these things. They'll use the first hour and then either the second, it'll just be in here, and then either the second hour we'll continue to do that, or we'll use just to finish up any last little bit that we might have, in the lecture slides. But I mean, we have